Usually in this, what is this, adipose tissue, right? In the adipose tissue, usually what happens is that, even in the muscles, okay, usually there's a blood flow transporters that are located there, right? And insulin helps to actually put the blood flow transporters, okay, into this peripheral, into this adipose tissue and striatal muscle, so that way more glucose can come, right? More glucose can come. But in here, because of the insulin deficiency, you're not putting these transport channels, okay, so that way the glucose is kind of like trapped inside the plasma, and they cannot go to your adipose tissue striatal muscles. That's what is happening here now. When this happens, okay, remember one more thing though. This adipose tissue striatal muscles, they are insulin dependent, okay? There are also some organs, okay, that does not require insulin. Glucose can just go, okay, without supply of insulin, okay? There are some of the insulin independent organs out there, like for example your brain, your red blood cells, okay, those are very important, okay, because they don't require insulin, okay, just know that. Now even liver too, okay, it's insulin independent. Now what is happening here is that, you know, this glucagon comes here again, okay, it has a receptor again, leading into this glucagon, okay, again 7-pass membrane receptors, epinephrine, norepinephrine, those guys are, you know, cortisols, they come here, okay, and what is going to happen is they're going to trigger, okay, with, again, this is a GS pathway, right, with the GTP, and then you guys know this, that you guys should be knowing of this off your head by now, ATP into cyclic AMP, right? And the level of cyclic AMP goes up and eventually activates a protein kinase A, right? In here in the adipose tissue, what it does is that, you know, usually if there was a presence of insulin will inhibit these enzymes, okay? Let's just write it down, these enzymes. And this is very, very important enzyme. What is this enzyme? This enzyme is called your hormone-sensitive, okay? It's called hormone-sensitive lipase. Insulin usually like inhibits this, right? Let's write down insulin here. This insulin usually inhibits this enzyme. But glucagon, what they do, by putting a phosphate group, they activate this hormone-sensitive lipase. And you know what hormone-sensitive lipase do? In the adipose tissue, what do you have? You have a lot of these fat cells, right? This is called glycerol. And this is what? The chain. Look, this, the glycerol with the 3 fatty acid, right? That's what it is. That's what it is. And a lot of this. Okay, so this, whenever there is this, the synthesis of by putting let's say, activating the hormone-sensitive lipase, what is going to happen is that this hormone-sensitive lipase start breaking down these are triglycerides, okay, they breaking down this tag, okay, and when they break down tag, what they release is that in a circulations, okay, let's write down here, they release lots of, okay, they release lots of what? Lots of your glycerol, okay, and then free fatty acid. That's what they do. That's what they're doing here, okay? Now, what is that process called? Whenever you are breaking down your fats molecule, this process called what? Lipolysis, okay? They call this as what? Lipolysis. So there's an increase in lipolysis, okay? Lipolysis. That's what is going to happen. So that means there is a decrease in what? If there's lipogenesis, right? That's what it is. So you increase lipolysis, or another way of saying is that you're decreasing the lipogenesis. That's what it is happening, right? Now, what is going to happen is this lot of free fatty acid and glycerol. Remember, these free fatty acids, okay, they get bound with albumin, okay, because they cannot just like freely circulate in your blood, okay. So they usually go and bound with albumin. That's what is going to happen, okay. Now, there are these, by triggering hormone-sensitive lipase from the adipose tissues, okay, you're breaking down lots of this free fatty acid. So level of free fatty acid in the blood and the glycerol is probably going up. That's what is going to happen. Now, this free fatty acid will again taken by the liver. Okay, look, this glycerol, what can I do? They can do the pathway of gluconeogenesis, so as free fatty acid, okay. But remember, what is going to happen is, it can it can keep doing that, okay? But then what is going to happen is, ultimately what is going to happen is that the level of oxo, because in order for the gluconeogenesis to happen, okay, eventually they will make acetyl-CoA, right? But the level of oxalic acid decreases, okay? That's what it's going to, so that means because there's a lot of the acetyl-CoA, and there's not much more oxaloacetate is present there, okay? And if there's not much oxalic acid there, you cannot run the citric cycle. So the citric cycle, let's say, becomes suppressed or becomes saturated, okay? That's what's going to happen. Because if this citric cycle cannot run, okay, because there's just so much of acetyl-CoA has been actually abundant of acetyl-CoA is present there, okay? So because there's a less oxaloacetate, okay, so you would not run the Krebs cycle. So your Krebs cycle becomes saturated. That's what's going to happen, right? Then what is going to happen? That's what we're talking about right now. So just like as I said here, okay, these free fatty acids, these are taken, okay, for the gluconeogenesis process, right? To break down, and then you trying to make glucose, right? That happens, okay? But ultimately what is going to happen is that, this acetyl-CoA, this free fatty acid, what is going to happen is that any cells that has a mitochondria, okay, those activate. Let's just make this as a mitochondria right here, okay? This is a mitochondria right here. What happens is that this glucagon path, this epinephrine, what they do is that they will activate your hepatic, okay, let's just write down, hepatic, okay, carnitine shuttle, okay? And this hepatic carnitine, so what they do is that they bring lots of this free fatty acid for what? For the beta oxidations, okay? And the mitochondria, that's what's happening, okay? So the increased level of beta oxidations happens in the mitochondria of the hepatic, okay? And this hepatic carnitine is the one that's going to bring this fatty acid, okay, in the mitochondria. And with that, what are you going to form? You're going to form a lot of what? Acetyl-CoA. That's what is formed. A lot of acetyl-CoA. And as I before mentioned that now, look, this citric cycle you cannot run because it's already saturated, right? Then what is going to happen is that lots of this acetyl-CoA, they have no other things they can do beside one thing, and that is to trigger the process of what? Very, very important. Ketogenesis, okay? Very, very important. This is now dangerous. So what is going to happen here is that high level of some of those lots of this acetyl-CoA, they get condensed, okay, and they get converted into, look, I'm going to write it down here, okay? Let's write it down here. Let me write it down in red, okay? In acetate. Acetate. That's what's going to happen, okay? And part of this acetate gets converted into your beta hydroxy, okay? Hydroxy butyric acid, okay? And some of them will be your acetone. Look at this. These guys, look, you see this? These three are known as your ketone bodies, okay? Ketone bodies. This is dangerous now, okay? And these is very, very dangerous because they can do a lot of damage. And these are ketone bodies, meaning what? These are acid, okay? Because remember, these beta hydroxybutyric acid, they contain a lot of protons. Okay, they contain a lot of protons. Because they contain a lot of protons, what is going to happen is that the pH level, because as when they come here, what is going to happen is that the proton group from this ketone bodies, they get deprotonated, meaning they get removed, okay? So a lot of protons are there. And whenever there's a lot of protons are there, what is going to happen? That's going to disturb the pH. So there will be a what? pH disturb, okay? And whenever there's a pH disturb, okay, or this proton is what is going to happen, it is making acidic, okay? So that is known as your decreased level of pH, okay? This is and this is acidic. And what kind of acidosis is this? This is a ketoacidosis. Okay, that's what it is. It's very, very important that you should know this, okay? And you see this acetone right here? Okay, this acetone is coming here too, okay? This acetone is a volatile gas, okay? What happens is this come here, okay? They go here, what is this capillaries? They can go here, acetone right here. Okay, go up, and then from this is your right heart. Okay, this is a trunk, your pulmonary trunk, and this is lungs. From here, the acetone you puff out. Okay, when you puff out, okay, it comes up from your mouth, right? And in your mouth, this acetone is volatile gas, right? This acetone, when you smell the patients of acetone, okay, you smell, okay, let's write it somewhere. It's very, very important. Lie around here. It's called, this is sweet, fruity odor, okay? The sweet, fruity odor, it smells like that. So, and this is one of the very, very important clinical manifestations that you see with a patient with DKA. That's what it is. Look, so pH is disturbed, right? So pH is going down. And remember, most of our body enzyme, they works in normal pH, right? So having this lot of pH is not good. It's not good. It's very dangerous, okay? Now, what is going to happen? This pH can do a lot of things, okay? These protons, okay? One thing that they could do is, because now there's a lot of stresses going on here, okay? One thing they can do is that, these protons, go and can trigger. Okay, what is this? What is this, guys? This is going to be this is, just think about this, a left common carotid artery or right common carotid artery, right? And then it breaks down into what? It breaks down into your internal and external carotid artery, okay? So if we say this is the left common carotid artery, this could be left internal carotid artery, and this is a left external carotid artery, right? And if you know that, from your cardiovascular system, there are bodies, they're like carotid bodies and the aortic bodies, right? You remember those? Okay? And they have those cells, like a glomerulus cells and all. Okay? But anyways, the most important thing here is that those bodies, okay? Those carotid bodies, okay? Around there, okay? They have the receptors, okay? And these are called peripheral chemoreceptors, okay? What is going to happen? They're going to stimulate those peripheral chemoreceptors down here, okay? On your carotid bodies. And what are they going to do? Whenever you stimulate the peripheral chemoreceptors, okay? That is going to trigger, okay? Because with the nerve attached, okay? That's going to report to the, okay? So, solitary tract nucleus. And what are they trying to do? Okay? That is the one way they will trigger the increase in what? Increase in ventilation, okay? Now, not only that, this protons, a lot of protons is there, right? What is going to happen is that there is your kidney will start it, okay, producing, because to balance this, okay, they'll start it, producing a lot of bicarb, okay, a lot of bicarb. So this proton right here, okay, let's just write down, okay, let's make this a lot of protons here, okay, there's a lot of protons, okay, that get mixes with the bicarb, okay, bicarb destroys these protons and gets converted into what? Your carbonic acid, okay? And this carbonic acid goes to makes CO2 plus water. That's what it's going to have, a spit in CO. Look, this is what is it? And this is CO2 is a less dangerous gas. The CO2 is what's going to happen. This CO2 can go, okay, look. This can go right here. Crosses the blood-brain barrier right here. Okay, this is in the medulla, and if you guys remember, there is something called your central chemoreceptors, right? In the medulla, and they can cross. CO2 is a lipid, so you can cross, and then cross. Let's say this is a blood-brain barrier. Cross, and then what? Mixes with the CSF fluid, okay, plus water, making it into carbonic acid again, and it splits into proton plus your bicarb. And this proton is going to stimulate your central chemoreceptors. And when you stimulate your central chemoreceptor, what is going to happen? You increase in respirations, okay? Ventilations. That means because you're trying to puff out more carbon dioxide. That is what you're trying to do. And that's what you're trying to do, right? And because, remember one more thing, that too much increased level of carbon dioxide level, okay? That can suppress this chemocenter, okay? So it's like medium or moderate level. That can trigger this, okay? And when this trigger, what is going to happen is what kind of breathing they'll have? They'll have this deep labored breathing, okay? That's kind of breathing. And what is that breathing called? Okay, let's write it down here. Look, lungs here, Okay, and if you remember, like, look, what is this? Normally there's a 500 ml of tidal volume, so you inspiration, expiration, inspiration, expiration, inspiration, expiration. That's what you usually do, right? But whenever there is a stimulations of the central chemoreceptors, it's going to have, like, look, long labored breathing, okay, deep labored breathing. These patterns of breathing, okay, because there's an increase in tidal volume, okay, this is known as your Kussmaul breathing, okay, Kussmaul breathing, and this is another manifestations that you see, patients with a DKA, okay, that's what you happen. Look, low pH, that's what's happening. Now, also what's going to happen? Whenever there is a low level of pH, low level of this, a lot of protein is there, right? You know what's going to happen? That, guys, do you know let's write down here, okay? In your circulation, what happened? Like calcium, what is happening to calcium? Usually calcium is bound with what? Calcium is bound with this plasma protein, like, for example, albumin, right? Let's say calcium here. And then some of them are bound with proton too. That's what it is, okay? Like this. Right? That's what's going to happen. Okay? So whenever there's a high level of proton, what is going to happen is that this proton, the hydrogen comes, and what happens is that they'll kick up this calcium, okay? And then they will start attaching. They start going and binding their albumin. So let's just say when they do that, a lot of calcium will be in your plasma. Okay? And a lot of calcium, whenever there's a lot of calcium in plasma, what do we call that? Hypercalcemia. So DKA, people can have a hypercalcemia. What should I write? So we'll write down here, hypercalcemia. Okay? Calcemia. Not only that is going to happen here. This, if you guys remember, okay, every cell has what? Okay, write down here. Let's write in the kidney here. There's a pump here, okay? In a basal. What is this? You're throwing 3 sodium out and bringing 2 potassiums in, right? And this is by ATPase, okay? And normally, if there is when the insulin is there, okay? Insulin is there. What happens is that glucose are enter, right? The glucose is there. And then remember, from the glucose you make ATP, right? All this pathway from the electron chain, right? You make this, and this ATP is used for this sodium potassium pump, right? So if, let's say, this decreased level of your glucose is decreased or low, okay? And I'm talking like any cells, okay? So what is happening here is that, there's a decreased level of ATP. So in that case, can you have this? Do you think this pump will work efficiently? Probably not, right? So if this pump is not going to work efficiently, some of the potassium will remain in a plasma. Okay, some of the reason in that one of the reasons some of the potassium will remain in a plasma because of that. And other thing is that that there are, okay, what is this? Let's say collecting table talks here. There are especially like cells, even in the basolateral cells, not only the sodium potassium, okay, they also have this pump which is called what? HKA. So hydrogen potassium pump. Well, this is what? It's an anti-port, right? So what they do is that they bring, proton in and send potassium out, okay, to the extracellular fluid. Okay, that's what it does. So whenever the level of proton is going up, okay, that means what is happening? You're making more acidic environment. This proton will, because there's a higher constant of proton, what happens with this pump, they will get exchanged. So in that case, what is happening is potassium level, more potassium is going to extracellular fluid, okay? So that is the 2 reasons why the potassium is going up, okay? And whenever there's a potassium level in the blood goes up, what do we call that? We call that hyperkalemia, okay? There's a hyperkalemia, and this is also, you can see this with DKA. Guys, this is very, very important. This hyperkalemia can kill the patient because this hyperkalemia can cause arrhythmias, okay? And if you arrhythmia, and that can kill the patients, okay, in heart, okay? So it's very, very important that, whenever you give a treatment, okay, you need to monitor the potassium level, okay, extremely well, okay? Giving too fast or giving like excessive, okay, treatments, okay, that can kill the patient, because excessive treatments or excessive amount of insulin can work this pump so fast, or the activity will increase, more potassium will relatively go inside the cells, and then, hyperkalemia may not kill the patient, but the decreased level of potassium can kill the patient, hypokalemia, okay? So it's really important that you monitor the potassium level. So when you treat the patient, you treat it gradually. That's something that you have to remember, right? Now, after this, okay, what else is going on here? Look, this bicarb are produced from where? From the intracardiac cells of the kidneys, right? Continuously they're producing, okay, because there's so much of acidosis. So what is going to happen is the bicarb level in plasma, that will go relatively down, right? That's what's going to happen here, okay? That is happening here, relatively go down, okay? And what is the normal level of bicarb usually? Usually about like from 22 to 28 milliequivalent per liter, okay? But then in this case, it might go down to like 15 milliequivalent per liter. That's what's going to happen, okay?